If you do not consent to being recorded, you are asked to drop off the session at this time. Okay, thank you. As is customary, we'll start this meeting in a good way, and I'll ask my co-host, Chairman Tim Davis, NIHB Billings Area Representative, to provide us with an opening prayer. You're on mute, Mr. Chairman Davis.
All right, keep forgetting about that button. But thank you, Treasurer Moose. Thank you very much. Just ask the Creator that we come before now at this time to enlighten our minds and our hearts to do what we need to do for a betterment of our people, and that we come together in a good way to begin this dialogue and the opportunities for our people to begin to receive healing, and pray for all those that are in the hospitals now, those who are experiencing, close to death, and those that are being born. We pray for those in our care centers, all those that are struggling with addictions. We pray for the mental health of our people is really something that needs to be addressed. And we're glad we're having this meeting. So we just thank our Creator for this opportunity, and God bless everybody. Wish everybody a happy Easter, and hopefully we can have a good spring going forward and our getting back together, coming out of this pandemic and healing. So we just ask our Creator to bless us, guide us, and protect us as we go forward. And ask special blessings on all of our veterans, those who sacrificed so much so that we could have freedom. And the people on this call, we just thank them for being here, and for all the participants that they'll be open their minds in a good way. We ask this through our Creator, and in His name, amen.
Miigwech, and thank you, Chairman Davis, for your words. During the session, we will begin speaking with leadership from the Substance Abuse and Mental Health Services Administration and the Indian Health Service Division of Behavioral Health. Today, we are joined by SAMHSA's leadership, Dr. Myram Delphine Rittman, and Assistant Secretary for Mental Health and Substance Abuse, Captain Carrie Hurd, and the Director of Office of Tribal Affairs and Policy, Mrs. Kimberly Benitez, Public Health Advisor. We're also joined by IHS Division of Behavioral Health Leadership, Dr. Glorinda Segay and Mr. Daryl Laroche. We appreciate the engagement with Dr. Delphine Rittman and Dr. Segay. We are looking forward to discussing a host of issues that are important to our tribal nations. To lead the session, I'm also glad to be joined by Chairman Tim Davis, again, Billings Area Representative, and Council Secretary Gwen Porter of the Great Lakes Plains area as an alternate. Chairman Davis.
You're on mute, Chairman Davis.
Again, I keep forgetting my mute button. Sorry. So on our talk, we began today. We just in a good way. So I'd like to say hello to Dr. Segay and everybody that's on this call. Chairman Bill, thank you for setting this up and this opportunity to go forward. We'll be, I guess, Mr. Moose, you're hosting this, so my part will be to join in when I'm called upon. So at this point, you want me to go over the talking point on that Chairman Bill was going to do, or is that still the agenda item? I forgot to get that clarified before we started. Sorry.
Yeah, no, you're just requesting just a couple of comments.
Okay.
With regards to a couple of the important topics that are facing tribal nations on the behavioral health challenge, and also the COVID pandemic impacts.
Thank you. So with the needs in Indian country where I sit in Montana, we have a very high rate of addiction with our youth, and we've had last month we had 4 deaths from overdose, and the COVID effects of long term, I guess the mental fogness, the respiratory stuff that still lingers in our people. So the resources that we would like to receive is just, as a tribal nation, equitably distributed and assure that, we're not forgotten like we've been for so long, the forgotten American at the bottom of the economic pyramid. So this opportunity to bring this forward it's really grateful to have this opportunity. So we just like to continue to ask SAMHSA to really focus in on our mental wellness facilities for our youth, and they're our future. And it seems like a lot of times there's very few resources available for our youth to receive for the care that they need from a mental health perspective, because it's so unable to be measured. Like we can measure our blood sugar, glucose levels, but for mental health, we have a very difficult time in addressing that in our particular reservation, because the Indian Health Service has really been the go-to agency, and they lack the resources, staffing, and resources for facilities to begin to get our youth healed. And all this trauma we faced throughout our history is well documented, and the effects of the lingering that has been a part of our culture and our history is on the forefront there. And we're kind of grateful for what's going on. The Department of Interior is putting out this boarding school initiative and that type of stuff that happened to our people. So we just really look forward to this opportunity to begin this dialogue and go forward in a good way to receive resources that are desperately needed in the Indian country across the nation and in Alaska as well. So, we just would like to thank again for this opportunity as we go forward.
Thank you, Chairman Tim Davis. Yeah, as tribal leaders, we appreciate the time that we have with Assistant Secretary Dr. Segay and other tribal behavioral health leaders, so we can share our guidance or recommendations on a variety of issues. This is a dynamic time. We want to ensure tribal leader perspectives are heard and understood and incorporated in the agency's work. And now I'll turn it over to Councilwoman Porter.
Thank you. Thank you, Chairman. We will begin today with some updates from Dr. Delphine Rittman and SAMHSA. This will be followed by some updates from Dr. Laroche and Dr. Segay from the Indian Health Service. Following these brief updates and comments, we'll begin the open discussion portion of the meeting. And now to start us off with some important SAMHSA updates, it is my pleasure to introduce Dr. Delphine Rittman. Dr. Delphine Rittman is currently Assistant Secretary for Mental Health and Substance Use in the U.S. Department of Health and Human Services and the administration of the Substance Abuse and Mental Health Services Administration. In her current and previous work, Dr. Delphine Rittman has been committed to promoting services and systems that are culturally responsive and foster dignity, respect, meaningful community inclusion. Dr. Delphine Rittman is joined by Captain Carrie Hurd, the Director of the Office of Tribal Affairs and Policy, and Kimberly Benitez, Public Health Advisor. Thank you all for making the time to be here with us for this important meeting. And I will turn the floor over to Dr. Delphine Rittman.
And thank you so much for that introduction. I do have to say it's such a pleasure to be here. We appreciate the opportunity to share some updates, but then also looking forward to the discussion and being able to hear input and feedback from the tribal members and leaders that are with us today. So again, so appreciate this opportunity. I want to briefly share some updates from SAMHSA, and then certainly looking forward to our questions and discussion. Next slide, please. For folks that aren't aware, just wanted to share our organizational structure a little bit. We do have 4 centers within SAMHSA. So the Center for Mental Health Services, the Center for Substance Abuse Prevention, the Center for Substance Abuse Treatment, and the Center for Behavioral Health Quality and Statistics. We also have 2 offices that support the centers, but then have additional offices as well. So the Office of Fiscal Resources, and then the Office of Management Technology and Operations. We also have an Office of Behavioral Health Equity, and then of course our Office of Tribal Affairs that Captain Hurd leads. Next slide, please. Wanted to share also our regional structure. So we do have regional administrators dispersed across the country in the regions. And so they often are our primary contacts, or a key contact anyway, because certainly within our Office of Tribal Affairs, there's quite a bit of work and contact that happens there. And then from a regional perspective, the regional administrators are also a key contact for tribes or tribal organizations and urban Indian organizations as well. Next slide, please. So, as many folks know, 988 is an area of work that we have been just laser focused on. We are so excited about this and see this as a real opportunity to expand and enhance our approach to crisis responsiveness. The 988 three-digit code will go live in July. And again, it will be an opportunity for people to be able to be connected to services and supports, and ultimately to, certainly be able to speak to a person live. And our long-range vision is that people are able to connect with, for example, crisis receiving centers to ultimately reduce unnecessary either emergency department involvement or involvement with law enforcement. So we're seeing this as a real transformation in terms of how we approach crisis responsiveness. We did do a tribal information session earlier in the year, and so it was helpful to, actually about a month ago or so, it was helpful to hear that information and feedback from tribal leaders. So we appreciated that time. Next slide, please. Transitioning to 988, again, we see this as just such a transformative moment for the country in terms of crisis responsiveness. Currently, some of our work is focusing on the crisis call center itself, but ultimately this diagram here depicts the full crisis care continuum that we're excited about. And again, as I mentioned, on May 3rd, we held an information session with tribal leaders to seek feedback and recommendations, and that was so helpful. So we look forward to continuing to get that ongoing feedback and support. Next slide, please. Also wanted to share some of our work related to the tribal behavioral health agenda. Dr. Captain Hurd and or Captain Carrie Hurd, rather, our Office of Tribal Affairs and Policy, is essentially beginning the process of updating the tribal behavioral health agenda. This document so continues to serve as a blueprint for informing, prioritizing, and really harmonizing our work with tribal communities. It reminds us that the tribal and federal governments, that we need to work together. And as we emerge from the pandemic, we expect that it'll be critical that this document reflect our new reality. So this is currently an area of ongoing work. Next slide, please. Also wanted to share some information about some of our funding, and we believe our funding is just one example of our ongoing commitment to tribal citizens really across the country. And so these are just a few examples of resources that were disseminated over the past year. For example, in FY 2021, SAMHSA awarded over $170 million to tribal grantees. And also we continue to fund tribal-only grants and set-asides, and you'll see some of those listed there. We also are in the process of releasing our FY22 Notice of Funding Opportunities. So do take a look at those. They're available on our website. And please share those far and wide. We need to and are interested in having as many different applicants as we can from those to include from tribal communities, especially, and of course, for our tribal only grants. So do share those far and wide because we're always looking to expand our grantees that we're working with. Next slide, please. We recognize that the fiscal commitment is an important part of our approach and work in terms of tribal communities. But we're also really excited about and interested in impacts. And often what we see in terms of the impacts, we see real impacts being made at the community level in terms of behavioral health. So I want to share just two examples of tribal grants where we're seeing really important impacts at the community level. So for example, for our Native Connections grant, this is a grantee in New Mexico, our 5 Sandoval Indian Pueblos. This grantee serves a consortium of about 5 tribal communities. You see those listed there. A majority of the services are provided by tribal members in a manner that is aligned with the values of tribal sovereignty, tribal culture, community integrity, and respect is also preserved. And you'll see the goals of this grant. The goals are to develop appropriate standards of care, to implement advocacy strategies through promoting wellness among tribal youth and their families, also creating post-intervention protocols in response to suicide attempts, as well as suicide contagion and cluster suicide, which unfortunately we see that at times. And then promoting overall community health and wellness. The target goals of this grant program is to serve about 25% of the youth in tribal communities annually. Next slide, please. So this next grant is the Tribal Opioid Response Grant, and a grantee that I'd like to highlight is a Cherokee Indian Hospital. This grantee is utilizing just a broad range of strategies to be able to impact individuals at the community level, including such things as offering the evidence-based practice of medication-assisted treatment, safety seeking or seeking safety, also the Red Road to Wellbriety, individual and group and family therapy, trauma-informed care, cognitive behavioral therapy. So you see just a range of strategies. And the services are offered through a combination of both in-person, telehealth, and also telephonic interventions. In 2021, the grantee administered about 492 buprenorphine doses, about 50 Vivitrol doses, and about 171 naloxone doses. Next slide, please. I also want to call your attention to our technical assistance centers. And so these two technical assistance centers are available to provide TA not only to grantees, but to others who may need technical assistance that are working with tribal communities. And so certainly share information with others that you may know that are interested in receiving technical assistance related to their work with tribal communities, because these are a valuable resource and we can provide TA across the country. Next slide, please. So I'll stop there, but definitely looking forward to our questions and discussion. And again, thank you so much for the invitation to be able to be here with you all. Thank you.
Thank you so much for those updates and that important information. Now we will hear from Mr. Laroche and the Indian Health Services.
Hi, good morning and good afternoon to everybody. As always, thank you very much for the invitation to participate in this listening session. I'm Daryl Laroche. I'm a member of the Lower Brule Sioux Tribe, and I serve as the Director of the Office of Clinical and Preventive Services for Indian Health Service. I'll just make some quick comments, and then I'm going to turn it over to the person who really knows everything about the behavioral health, Dr. Segay. But I was struck by something that Chairman Davis had mentioned in his opening talk about how things are interconnected, and you know that we've been going through COVID for the last couple of years, and he mentioned diabetes. I'm looking at oral health, maternal health, and so forth, and how really our mental health is kind of at the intersection of all of that. So this is a tremendously important topic. Also, I'm glad to see our colleagues here from SAMHSA, as well as others that will hopefully be participating in the future, because we really can't do this on our own without that collaboration of other organizations, the tribes, and federal agencies. So with that, again, thank you so much for the invitation. I'm going to turn it over to Dr. Glorinda Segay, our Director of Behavioral Health, and she's going to give some updates. So Dr. Segay.
Thank you, sir, for the kind introduction. My name is Glorinda Segay. I'm a tribal enrolled member with Navajo Tribe from Navajo Nation. So everything Mr. Laroche had indicated, I second that. So thank you. And also to hear from our colleagues, Dr. Delphine Written. So thank you for that. So if I could ask for your attention to our slide deck there. So if you can go ahead and move to the next slide. Thank you. So here's just an overview again, as far as what DBH pretty much our responsibilities and our functions there. So we are housed in the Office of Clinical and Preventive Services. So we pretty much refer to that program as OCPS. And so we do serve as a national advocacy. We do a lot of policy development as far as just how things are going internally. Just for example, the intact tag there. We also do management and administrations of behavioral health. We do have an alcohol and substance abuse program, and we also have a family violence prevention program for all of our American Indian and Alaska Native people. So here we have 4 functional areas. So one is the alcohol and substance abuse. The other one is mental health. And then of course, our Telebehavioral Health Center of Excellence. And lastly, our behavioral health initiatives. So we do work in partnership with tribes, tribal organizations, and urban Indian organizations. So we do coordinate national efforts to share knowledge and build capacity through development and implementation of evidence-based practice, and also a big emphasis on the cultural-based activities across Indian country. Next slide. So here I just want to make mention that I wanted to share with you all what the hot topics are within Division of Behavioral Health. So here's a list there as we go forward. So again, these are most current that had came to Division of Behavioral Health. Next slide. So the first one comes from our alcohol and substance abuse program. And so this one will talk about the polysubstance use and overdoses. And so since the pandemic, it seems like, there's been an increase there. So just wanted to share some stats here. CDC reported the AIAN population has the second highest overdose rate from all opioids. And so the highest rate would be from prescription opioids. And then the overall rate of overdose deaths increased by 13% between 2015 and 17. And then in 2017, the rate of drug overdose deaths was 9.6% higher. Then looking at the overdose death rose more than 500%. And then lastly, again, CDC's provisional overdose death rate for 2021 estimates over 100,000 deaths, which is an increase, and it puts a need out, to help to respond to the overdose of this epidemic. So again, reports have indicated that there are other illicit substances. They've traced back to fentanyl, which causes the overdose. And so this is pretty much referred to as polysubstance use. And so other substances includes methamphetamine, cocaine, crack, and marijuana. And of course, alcohol seems to be a contributing factor to overdoses. So with this, this is what pretty much put a need out to, reach our underserved, our very rural areas, the urban areas, and our special populations that live in our tribal communities. Next slide. So here, I just want to, again, indicate that background information. So the alcohol and substance use disorder treatment and prevention has transitioned from IHS direct care services to local community control via tribal contracting and compacting. So IHS's role has shifted to providing support to enable communities to plan, develop, and implement culturally informed programs. Again, a lot of these local areas are more in tune than we are at a national level, so we always have a lot of meetings to discuss, issues as far as, what can we do to help, the local areas with what they're presenting with. So they're all different. And then again, IHS received funding under the Special Behavioral Health Pilot Program. And so this one was to address the opioid epidemic among our tribal communities. So at the time, we did hold tribal consultations and urban confers to help the development of the IHS Community Opioid Intervention Pilot Project. So we refer to that as the co-op. So in 2021, IHS awarded 35 tribal communities at approximately $500,000 per year, totaling about $16 million, to develop culturally appropriate prevention, treatment, recovery, and aftercare services for opioid use disorder. Next slide. And so we'll go ahead and move into our mental health. And so again, two of the high-level items that came up with the mental health is the 988. So thank you to our SAMHSA colleagues who really broke it down very well. And so where we play a role in the 988 is making sure, again, that Indian country, has an opportunity to voice the concerns about the new 988. So I was really happy to hear about the listening session. So just a little background here. July 16, 2020, the Federal Communication Commission approved the 988 as the designated National Suicide Prevention Lifeline. Telephone and telecommunication service providers were given a 2-year period to transition 988 for a suicide prevention. So again, the National Suicide Hotline Designation Act of 2020 was signed into law in October. So this act amended the Communication Act of 1934 to designate 988 as a universal telephone number for suicide prevention and mental health crisis. So I just want to make mention there, this is not only for suicide prevention. Again, it includes a mental health crisis of all sorts. So I just want to clarify that. Again, the whole objective is to help, stabilization with suicide and other mental health crises. And so again, the new 3-digit number will go live. So here's an important date, July 16, 2022. So keep that in mind moving forward. Next slide, please. So here, current status is SAMHSA, in collaboration with the White House, has begun convening work groups focusing on priority areas of workforce development, 911/988 collaboration, financing, data technology, public education, as well as working with special interest populations, such as our tribal communities. And so our Division of Behavioral Health, the National Suicide Prevention Consultant, who is Dr. Pamela Indehorn, has been providing subject matter expert consultation to SAMHSA, focusing on the needs and the unique challenges and opportunities that are related to our tribal communities. So I just want to make mention of that. Next slide. So here's another item we thought was very important to share. So the mental health disparity throughout Indian country. And so again, with the pandemic that's ongoing, as well as the boarding schools, so we're seeing, a lot of effect across Indian country. Next, okay, so here, something happened to my, there you go. So again, American Indians, Alaska Natives, pretty much comprised of approximately 2% of the U.S. population. So again, 2/3 live in urban, suburban areas or rural non-reservation areas, while 1/3 resides on federal reservations. As of 2022, there are 574 recognized tribes. Next slide. So here, we do have studies, again, that are out there, pretty much shows suicide rates, the increase, we're seeing post-traumatic stress and violence and substance use disorders there. And so just want to make mention that these rates, pretty much are 2.5% more than our general population. Next slide. And so telebehavioral health, again, could you go to the next slide? Thank you. So we do have a telebehavioral health program that was established 14 years ago. So Dr. Christopher Ford, he is tasked to this. And so basically we do have 23 sites right now, and we're continuing to receive requests to have more telebehavioral health services. Next slide. So here again, just a little bit of more information with the current status there. And so there's a number chart that's given there at the bottom. And so just wanted to share that information. So I apologize, but I'm going to try to push through the slide decks here. Next slide. So behavioral health initiatives, basically we do have some grants that we've recently awarded. So those grants are made mention here, the substance abuse and suicide prevention program. So this is the former program, the MSPI. And so with this one, this just gives a background of, the past grant that was put out there. And it was a 6-year funding cycle from September 30th, 2015 to 2021. And so there's some focus areas that are mentioned there. So one of them is suicide prevention. And so total amount was $27.7 million given to 174 projects. Next slide. So here's a breakdown of our current awards there. So as of May 1st, we did fund a total of 72 tribes there. And so this is basically an amount of $27.47 million for 5 years. So just a breakdown there. These slides will be available for you to look through it. Next slide. Then the DVP, also known as a DVPI, so just some background there. Back in 2015, there was 57 grants and federal awards that were made to the tribes. So for the UIOs was $7.5 million. And then going to September 30th, again, we got additional 26 awards for the programs there. So that was $3.5 million, so totaling $11.1 million. Again, for overall 83 projects for 5 years. And so we did allow for an extension just because of the pandemic. Next slide.
And you'll have about 2 to 3 more minutes, Dr. Segay. Thank you.
Okay, thank you, sir. Thank you. So here's, again, the current status. So we did make an award there to 40 tribes, so totaling $8.4 million for 5 years, and there's a breakdown there. Next slide. And our behavioral health integration also pretty much has been awarded. So there's 14 grants that were made available. And so again, the focus here is the implementation of the delivery of behavioral health services. So we're talking about trauma-informed care, nutrition, and exercises, and so forth. Next slide. So VSI, here is another grant that's been awarded. And so the focal of this is the suicide. So we do also have a cooperative agreement in addition to the actual grant there. So we've awarded 8 grants. So we're very happy about that. Next slide. And here's a new notice of funding opportunity. So this is the zero, we call it a VSI-CC. So there's the date information and the web link if you're interested. Next slide. And so this just talks about the purpose of the grant there. Again, it's just a cooperative agreement to build capacity of the VSI project. So this one works hand in hand with the VSI grant. Next slide. And so just a total amount of $500,000. So we're looking at approximately 1 award will be issued for this one, and this is going to be for 5 years. Next slide. So lastly, the INTAC, National Tribal Advisory Committee. So we are seeking representatives for the areas that are listed here. And so we are going to announce a meeting in June, and so we'll share details. So that concludes my presentation. Thank you very much. And back to you, Mr. Moose.
Thank you very much for those updates and important information. Now we'll begin the discussion portion of our meeting. Like other listening sessions, we'll follow tribal protocol, invite our tribal elected leaders to make comments, share their recommendations, and ask questions first. Once our tribal leaders have had a chance to speak, we will open the floor to other members of our audience. Our National Health Board of Directors will have a few questions to start us off with. I would like to invite NIHB Board Chairman, Chief Bill Smith, to ask the first question.
Misuse, Sam. Thank you. Laishu Dukte Nahatyu. Hello, my name is Chief Bill. I am of the EAC people, and I'm the chairman of the National Health Board and also a Vietnam vet. And when we talk about suicides and we talk about mental health, this is important because American Indians and Alaska Natives also have stood up more often than not, and coming home is a hard thing. And when we talk about alcohol abuse and we talk about substance abuse, those are painkillers for the veterans. And we know we'll never get fixed, but we can learn to live with what we had to do when we did our time. So beginning with that, I'd like to say there's a dire need to fund behavioral health programs for the American Indians and Alaska Natives. Even before COVID-19 pandemic, Alaska Natives and American Indians communities experienced some of the largest disparities in mental and behavioral health outcomes. The COVID-19 pandemic has made this worse, especially for Native youths. For example, in 2018, surveys found that American Indians and Alaska Native youths in the 8th, 10th, and 12th grades were more likely than the non-Native youths to have and used alcohol or illegal drugs in the past 30 days. In 2020, drug overdoses was a leading cause of death for American Indians and Alaska Natives aged 25 to 44, and was in the top 4 leading causes of death for all American Indians and Alaska Natives age 45 and older. Epidemics, exceptions only by COVID-19 and age-related illnesses, overdose deaths involved opiates increased 6-fold during 2000 to 2016, the largest increase in any group. In 2020, suicide rates for the general population decreased 3% from 2019. However, suicide rates increased for American Indians and Alaska Natives males during that same period. And Alaska Natives and American Indians continue to have the highest suicide rate of any domestic group. In 2020, suicide was the leading cause of death for the American Indians and Alaska Natives 10 to 14-year-old, and the second leading cause of death for the 15 to 24-year-olds and our veterans. These status reflect both the intergenerational trauma that many of our communities face and need for additional support to address this trauma. SAMHSA needs to be more engaged and active partner, ensuring that our programs are well-funded and sufficient support to address these problems adequately. As the Office of Tribal Affairs and Policy grows under the leadership of Captain Hurd, it is our stress that the Tribal Division version of the Office of Tribal Affairs and Policies must start with a meaningful and robust input and feedback from tribes. SAMHSA must include tribes in strategic planning to address numerous mental health and substance use disparities, inadequate, unique to American Indians and Alaska Native experiences. We commend SAMHSA for the work over the last year, and we're looking forward to continue on this journey together. And I'll bring you up COVID-19, and then I'll turn it back over to Sam. We have questions about the service and support for our communities as we deal with the short and long-term impact of COVID-19 on mental and behavioral health. We need to take steps to help lessen the mental and behavioral health consequences associated with COVID-19 and to help people cope and heal. In addition to serving related to the impact COVID-19, we need preventive programs for vulnerable populations that promote wellness and healing across generations. These kind of services have not been provided for by COVID-19 relief funds. And I have 3 questions for you. Question number 1, what support service and resources will be available for those experiencing mental and behavioral health impacts from COVID-19 currently and as we continue to move through the pandemic? And then question number 2, is certain services such as telehealth were expanded during the pandemic due to the declared state of emergencies. What can be done to preserve these benefits? Service expansion, even when it is no longer in the state of emergency or receiving COVID specific funding. And the last question, is SAMHSA looking into any links to increase its suicides due to the pandemic? If so, what information could you share with the tribes? And will there be additional fundings to address these issues? Awata, thank you.
Yeah. So, I just want to thank you for your feedback and for your questions. I appreciate the just the nuance and detail that you shared. I mean, I think a lot of that is just it's important for us to know, and critical information as we're thinking about programs and services. I do want to get directly to your question though. So in terms of mental health and substance use funding and resources, absolutely. So we're committed to continuing to provide a broad range of mental health and substance use related resources. To include right now, there is the Tribal Opioid Response Grant that I believe was, that is now live. And so we are looking for just a broad and hoping for a broad range of applications there. There have been instances in the recent past where sometimes we don't necessarily get as many grantees as we have resources. And so we're hoping that we have a broad range of grantees there. And then even in terms of, mental health, many of the grants that I mentioned, so the Community Connections grant, as well as others, we're looking to continue to offer those resources and those grants. We have seen them make valuable impacts at the community level. You also asked a question about telehealth. And so absolutely, there is an interest also to continue, many of the telehealth flexibilities beyond the public health emergency, particularly as it relates to offering medication-assisted treatment via telehealth and other forms of substance use treatment as well, mental health treatment as well. So that is certainly one area of interest. Then finally, within our NISDA data, so National Survey on Drug Use and Health, for the past, the survey that just came out, as well as the one that is currently, will soon be analyzed. Actually, I think they're analyzing it right now. We did have questions that looked at the impact of the pandemic, both on mental health and, for the previous year, so the 2020 NISDA did show that people often reported that the pandemic had a negative impact on mental health and overall well-being. And we saw increased rates of, or reports anyway, of suicidal ideation among young people and attempts. And then when we looked at that broken down by race and ethnicity, we did see that members of tribal communities had higher rates of suicidal ideation and several of the suicide related questions. And we can certainly share that data. We'll be able to look at similar data with the current NISDA that's coming up. But I think the thing is particularly important is it lets us know that we have more work to do there. It lets us know that the work that is underway with 988 is vitally important. And so that's why we have we'll continue to do the tribal consultations. We want to get that feedback. We need to get feedback. And as it was mentioned earlier, that resource is for individuals not just struggling with suicidal feelings or ideation, but in any form of mental health crisis. And technically, if they're struggling with substances as well. So any form of crisis that an individual may be in. Over time, we're going to further build out and strengthen the substance use component and resource component of that as well. So just a few quick responses to your questions, but appreciate your questions and commitment and dedication to behavioral health as well.
I want to, and thank you for that response. Could I get the Indian Health Service to respond to those questions?
Yes, thank you for that information. So I just want to make mention as far as what programs we have within DBH, to address these issues is, again, we do provide care services to 574 tribes. So within DBH, we manage, develop and coordinate comprehensive clinical, preventive and community-based programs for mental health and also alcohol and substance use for IHS tribes, tribal organizations, and urban Indian organizations. So we do support mental health and substance use disorder screening, assessment, treatment, referrals for all AIAN patients, and our YRTCs, which is our Youth Regional Treatment Centers, who provide culturally relevant treatment and recovery services to our AIAN youth who are currently experiencing substance use disorders. And again, IHS is unique in the way we have a population community focus, and through the administration of their behavioral health initiatives in partnership with our tribal health programs, through our behavioral health grants initiatives. So some examples of our behavioral health initiatives include our recently announced funding opportunity of approximately $46.4 million for substance abuse, suicide prevention, DV prevention, domestic violence, behavioral health integration. So these funds will support the tribes in their COVID recovery phase to provide services at an individual or a community level, including the development of community coalitions and response teams. These funds also promote the use and development of evidence-based and practice-based models, interventions that represent culturally appropriate prevention, treatment services from a community-driven context. So you can go ahead and visit our IHS Gov website to learn about more of these opportunities. We can put it there in the chat. And so again, just want to make mention, of our awards, that I made mention of earlier. That's really one way to really help to combat a lot of these issues that are ongoing there. And so we also received approximately $4.3 billion from the American Rescue Plan Act. So of those dollars, $420 million, IHS has distributed as far as mental health and substance abuse prevention and treatment centers. So again, the vast majority of these funds were distributed as a one-time, non-recurring funds to IHS federal and tribal programs, as well as UIO. So more details you can find on our IHS newsroom website there. So back to you, sir.
Thank you very much for that response. And also, I know that the Indian Health Service and the VA have MOUs, and suicide prevention is a big thing. And when we talk about alcohol abuse, when you talk to a veteran, it's not alcohol abuse, it's painkillers. It's trying to numb the mind of what we went through. So as American Indians and Alaska Natives, we need that behavioral health, and we need the work between the Indian Health Service and the VA and SAMHSA on all our programs on the reservation. So Awata, thank you very much.
Yes, and thank you for those responses. Now I'd like to open it up for tribal elected leadership to ask their questions. Miigwech.
We have Councilman Lewis with his hand raised.
Can you hear me?
Yes, Councilman Lewis.
Thank you very much, Sam. Nicholas Lewis, Secretary for the Lummi Nation, Vice Chairman on the National Indian Health Board, and member of the SAMHSA Advisory Committee on the at-large seat. I do have two topics I'd like to talk about. One is substance misuse, and the second is the tribal behavioral health agenda. On the first one, I do have a few requests as well, and then one question, and then one question and request on the other item, just so we're aware. But first, I want to highlight the extent to which American Indians and Alaska Natives have been impacted by the opiate epidemic. A recent national study reported that American Indian and Alaska Natives have experienced the highest prescription opiate death rate of any demographic in 2019. We also had the highest percentage increase in prescription opiate deaths between 2016 and 2017 at nearly 11%. In 2020, American Indians, Alaska Natives had the highest age-adjusted overdose death rate of any group. Drug overdose was the leading cause of death for American Indians and Alaska Natives aged between 25 and 44, and was in the top 4 leading causes of death for all Native or American Indian Alaska Natives aged 45 and older, eclipsed only by COVID-19 and age-related illness. Starting in fiscal year 2018 and again in 2019, Congress enacted a 5% set aside in the opiate response grants for tribes and tribal organizations, and a 10% set aside for medication assisted treatment. Tribal behavioral health programs are frequently struggling because of the insufficient funding, and our programs are only funded for a finite period. Some of the requests I have on this one is we do request that SAMHSA increase access to residential youth transitional systems. We also request additionally SAMHSA should maintain the tribal set aside of opioid monies so that tribes can continue to build their prevention, treatment, and recovery infrastructure and capacity. Where possible, the agency should also use its discretion to increase the set aside amounts given the higher needs that have been shown in our community. We also request that SAMHSA create funding that allows for construction of tribal residential treatment facilities and provision of transitional housing. Also request that SAMHSA should double funding for tribal behavioral health grants for substance use prevention and mental health, and expand program flexibility to permit tribes to implement projects that are uniquely tailored to meet their community's needs. Also request that SAMHSA should engage in meaningful and robust tribal consultation to discuss the opportunities and strategies for restructuring the program as formula-based, which many tribes do prefer. The question I have for SAMHSA on this part is, cultural and traditional interventions need to be included along the Western methods of prevention. It can be hard to put a value on traditional interventions, but they do work in our tribal communities and for our tribal people. So the question we have is, how can our traditional practices be better acknowledged so that they are allowable for uses with federal funding? I don't know if SAMHSA wants to respond there, or do you want me to continue on to the next part? I know that was a lot.
Yeah, no, I appreciate your feedback and the detail that you offered there. I was writing feverishly in terms of, really wanting to be able to capture all of that. And so, yeah, I'll respond in a couple areas. So for one, in terms of the, being able to incorporate cultural practices along with, other evidence-based practices, absolutely. I am fully in support of that. And in fact, you'll see in many of our current notice of funding opportunities, there is language related to incorporating cultural practices along with evidence-based practices. So it's entirely okay to do adaptations and include cultural adaptations and cultural practices as well. We'll also be offering a guide around strategies for adapting evidence-based practices to be more culturally responsive. Much of my work over my career has been sort of focused just on this question, on ways in which evidence-based practices can be incorporated, and the importance and value of cultural responsiveness. That is, the services and supports reflect the cultural beliefs and values and worldview and practices and traditions of individuals that are accessing or connecting with those services. And it absolutely can be done. And when it's done, what we get on the other side is often quite impactful in terms of making a difference at the community level. So I did want to share that. In terms of the set aside and the resources that are that we're allocating for tribal practices or tribal grants. So some of that is decided by Congress, and so we are absolutely interested and will uphold all of that. And then even in terms of some of our discretionary grants, we have often tribal set-asides within those as well. So stay tuned and definitely do check out the range of notice of funding opportunities that are being disseminated, because I think it'll address some of those questions that you offered. And so I'll stop there because I know you had other questions that you wanted to ask as well.
Yes, thank you very much. The last part was on the tribal behavioral health agenda.
Mm-hmm.
So there is an urgent need to review and evaluate and update the National Tribal Behavioral Health Agenda to reflect the current behavioral and mental health services that are needed across Indian country. To create the previous agenda, SAMHSA, IHS, and the National Indian Health Board came together and engaged in discussions with tribal leaders and members, tribal administrators, tribal advocates who are all involved with our American Indian and Alaska Native health, and the federal agency representatives throughout an 18-month process which ended in 2015. A thoughtful evaluation on what was accomplished, what is left to be achieved, and what new or emerging topics within behavioral and mental health needed to be added or expanded on, and an updated agenda is needed. Let's build upon the work done before us and commit to strengthening the future of our tribal behavioral health and mental health services for our people. Our request that we did have was, we request that SAMHSA continues its support for a tribally driven initiative modeled upon the previous process of reviewing, evaluating, and updating the tribal behavioral health agenda to meet the needs and priorities of the tribes as we emerge from this pandemic. The question we did have was, has SAMHSA made any progress towards this request, and how will SAMHSA and IHS Division of Behavioral Health work together on this project?
Yeah, thank you for that question. I'm going to invite Captain Carrie Hurd to comment on that. Captain Hurd, I know, has been steeped in this, and we are committed from full of SAMHSA to update that in a way that's collaborative, and we've been talking quite a bit about that. So Carrie, can you share about the process that we have in place?
Yes, definitely, Dr. Delphin-Rittman. And we are looking to revisit the agenda much in the way that it was first created, definitely as a partnership between tribal and federal collaboration. So I think we shared with the TTAC initially in March when we met kind of our hopes around revisiting the tribal behavioral health agenda. We've been doing an internal review of it, trying to look at some of the statistics and other kinds of information that was shared initially and how we could update that internally. Then we will be reaching out to form a tribal federal work group to revisit and look at where our opportunities are, look at where we've maybe made inroads to success, and exactly how the landscape has changed since COVID and where we find our opportunities for collaboration and partnership. So we'll most likely be reaching out to many of you that are on this call soon to talk about how this tribal federal work group is going to come together and to ask for your partnership.
Thank you.
Thank you for those responses. Nick, did you have any other question?
No, that was it. Thank you. Doing a great job helping moderate and facilitate this. And thank you to our SAMHSA and IHS partners for being so engaged and responding to our tribal leaders. Thank you.
Yes, and thank you to our fellow board members for kicking off those questions. Now I'd like to invite tribal elected leaders in the audience to ask questions, share their comments, and provide recommendations. If you would like to speak, please use the raise your hand feature. Put your name into the chat box. Once you are recognized, you may unmute yourself and ask your question directly to our speakers. We ask you that you share your name, title, and tribe. Once you're recognized, we'll also invite you to turn on your camera if you'd like to do so, and then ask your question. Do we have any questions in the audience?
Yeah.
I do see Nate Tyler, treasurer.
Sorry, I couldn't find the raise your hand option on my Zoom here. But Nate, if you want to go ahead, if not,
okay.
I would.
All right. Yeah, I appreciate that. Thanks a lot. And I appreciate Dr. Delphin-Rittman and Captain Hurd taking part in this important discussion we're having right now. So Nate Tyler, treasurer of the Makah Tribe, treasurer of the Portland Area Indian Health Board, alternate to the National Indian Health Board, and I also sit on the SAMHSA. So truly do appreciate the dialogue we're having. So my first question is going to be on grants and funding. Tribal behavioral health programs frequently struggle because of insufficient funding, or programs are funded only for a finite period. Available funds are often limited and competitive with restrictive funding formulas, burdensome administrative and reporting requirements, and a compartmentalized approach that does not support holistic tribal behavioral health care that is comprehensive and culturally appropriate. For example, in 2021, a total of $2.475 billion in COVID-19 supplemental funding was distributed through the Substance Abuse Prevention and Treatment Block Grant and Community Mental Health Block Grant programs. However, only 0.034%, $556,786, was directly distributed to a single tribal awardee under the Substance Abuse Prevention and Treatment Block Grant. No tribe is eligible for the Community Mental Health Block Grant. These two block grants include the largest increases in SAMHSA's 2022 appropriations and in the President's fiscal year 2023 budget request. It is nearly impossible for tribes to benefit from these increases and behavioral health investments. This is neither equitable nor proportionate funding for tribes to build and strengthen their behavioral health services for their citizens. A couple of requests. Tribes must be granted equitable access to critical block grant funds to build the behavioral health services infrastructure that our people desperately need. Ensure grants are not overly restrictive and instead allow the flexibility for tribes to provide the services that they believe will best serve their communities. SAMHSA engages in a tribally led process to develop a formula for allocation and distribution of funds to allow for all federally recognized tribes to get funding. To honor the trust responsibility, SAMHSA should create a tribal set-aside in all funding opportunities. The agency should craft those opportunities as non-competitive. The agency should also streamline the application process and reduce reporting requirements to reduce the administrative burden on tribes. What can SAMHSA do to support the Native Behavioral Health Access Improvement Act that has been introduced into Congress?
Lyndon, I know you have to leave. Ms. Porter.
Thank you. I actually wanted to highlight the area on the mental health and suicide prevention.
Oh, I'm sorry. Dr. Whitman has to depart at this time.
Oh, I'm sorry.
Yeah.
Were you gonna?
Yes, I do need to jump off now, but I just wanted to again thank everyone for the feedback and for the questions. Captain Hurd is going to remain on, and also Kim Benitez is going to remain on as well, and they will follow up with me in terms of the discussion. But I do want to certainly let folks know that we are. I hear the feedback and the recommendations that have been offered so far. And appreciate you bringing that forward. The last question around what can we do in terms of influencing Congress to authorize us to use funding in some of the ways that were recommended. Certainly one thing that we can do is bring these recommendations forward. And so that is, certainly something that we're able to do as we interact with members of Congress to share the recommendations and the asks that have come from this meeting and others. And so we will do that. We have a legislative office that interacts regularly with members of Congress and can certainly use that as one vehicle to share some of the recommendations that have been offered here. But just know that we are interested in continuing our collaborations, particularly as we develop and update or update the tribal behavioral health agenda. I know that was mentioned earlier as well. And so we are interested in continuing some of that work together. But again, I want to thank everyone and just appreciate the opportunity to be here and share the time and space. So thank you. Take care, everyone.
Thank you, Ms. Rutman. We will now continue our critical discussion, and I'll turn the floor back over to Mr. Moose. Or not. I think it's my
Sorry.
section. That was, I think we were to just continue the discussion that Mr. Rittman or Miss Ritt, Dr. Rittman left off on.
I think we were on Councilman Tyler's question. Councilman Tyler, would you like to finish, or was that it?
That was it. The only thing I wanted to cover on the grants and the funding.
Ms. Porter, I know you had a question.
Okay, yeah, just to pick up where we kind of left off, one of them is on mental health and suicide prevention. And I know we shared a lot of statistics and data and in regards to American Indians and Alaska Natives. And a request that I have is that we ask that SAMHSA support and resource comprehensive suicide prevention efforts, including integrated behavioral health services, screening and assessments, coordinated crisis response and protocols for youth and adults, and ensured continuum of care. And another request that we have is that ask SAMHSA to support and fund tribally led comprehensive substance use disorder programs that provide a full continuum of wraparound services. This includes support for primary prevention programs, residential and dual diagnosis treatment facilities, peer recovery support systems, harm reduction services, medication assisted treatment, intensive outpatient therapy, transitional housing, and diversion programs. So that is a request that we have in regards to the mental health and suicide prevention. But another one that I would like to highlight is on tribal law enforcement and behavioral health. Vulnerable tribal members who are struggling with substance use disorders often find themselves caught up in legal problems and systems that promote punishment over treatment. Sadly, many who struggle with mental health concerns also experience negative outcomes from law enforcement when reaching out for help or exhibiting symptoms. All too often, law enforcement officers are not adequately trained in how to recognize signs and symptoms of mental distress and may respond to a crisis in unhelpful or even damaging ways. In addition, tribal law enforcement officers themselves experience stressful and often traumatizing work as they serve their tribal communities. Efforts have been made to help the community-oriented policing services. Office of the Department of Justice implemented programs in fiscal year 21 in response to Law Enforcement Mental Health and Wellness Act of 2017, aimed at improving the provision and access to mental health services for law enforcement. Solicitation was open to federally recognized tribes and their public agencies, but tribes were once again subject to limited competitive funding. Tribal law enforcement is in need of meaningful behavioral health integration to protect both the community and the officers who serve. Meaningful behavioral health integration for tribal law enforcement includes two components. One, to support the mental health and wellness of tribal law enforcement officers by addressing work-related PTSD, offering peer support, suicide prevention resources, debriefing and increasing access to mental health services. They also need messaging that reduces stigma around seeking help for mental health concerns and resources for increasing cultural connection as a source of strength and resilience. And two, the support, the training and competency of tribal law enforcement officers to recognize signs and symptoms of mental distress and substance use in community members they may encounter while on duty, to reduce punitive, responsive, and increase opportunities for vulnerable citizens to receive much needed mental health and substance abuse services, and to integrate behavioral health professionals who can assist with screening, assessment, and culturally appropriate referrals. And the request, SAMHSA can support mental health treatment and training of tribal law enforcement through the expansion of funding opportunities for tribal behavioral health services to pursue integration and partnerships with tribal law enforcement. Non-competitive funding allocated to tribal specific and culturally responsive training is needed to address the unique needs of tribal law enforcement. So that is our request.
So thank you so much for sharing that thoughtful request. It is noted, I will share that my office, BIA, DOJ have been meeting together to see how we can collaborate our efforts as far as supporting law enforcement, supporting healing to wellness courts, recognizing the impact on tribal citizens that are experiencing substance use disorder or mental health crisis when they encounter law enforcement, but also the impact on the law enforcement officers themselves that are often tribal citizens as well, right? So how do we coordinate all of our resources to best kind of serve as a federal government, these tribal citizens and the law enforcement officers that serve them. So we're hopeful that we're going to be able to provide some training and support for the law enforcement officers in partnership with BIA with some existing resources that we have, but then we'll also be thoughtful about creating resources in the future. Additionally, I would like to say too, I would encourage you to take a look at the Tribal Opioid Response Solicitation that is open currently. That grant can serve not only opioids, but also stimulants. And it really supports the cultural wisdom declaration from the Tribal Behavioral Health Agenda, giving great flexibility on activities and implementation, of different culturally responsive treatment. So prevention, treatment, recovery, harm reduction. So kind of the whole continuum of service.
Looks like we have Chairman Davis with his hand raised.
Thank you. Along with those treatment facilities, also, a lot of our people need detox, and it's a difficult situation to receive that here in my community. It's a long process where you have to wait for a bed, or there's no facility available to provide detox. And so it's like they come now and they want it now, but they have to wait. And so they're kind of stuck in this waiting mode where, but by the time some commit suicide, some overdose. But 2 years ago, we had a police officer that committed suicide that was waiting for this coordination effort between the DOJ, BIA, and he was asking for a treatment. And before they could get in there, he unfortunately committed suicide. So just a comment there to try to increase the capacity of detox as well as the treatment and prevention. That's one issue we face here as a community of not having that quick opportunity to be detoxed. A lot of our people have to wait, and that causes a lot of problems for those seeking assistance. Kind of a waiting game, kind of, so to speak. But so in regards to providing additional funding to get those youth regional treatment facilities, also to provide some mechanisms for substance disorder detox would benefit our communities.
So sorry to hear of the loss of that officer and his inability to access treatment. I know our law enforcement officers put themselves out there every day, for our communities, and I'm very sorry for that loss. I will share that we've also heard this from the Secretary's Tribal Advisory Committee about the need for detox. Stacey Ekefi's group over at IAA has been working to get together a convening, of the HHS agencies that may have resources in this respect, so we can look at how we may be able to increase access to that very important service.
Thank you, Captain.
Thank you. We do have another, Diane, would you like to ask your question? Your mute is still on.
Sorry about that. Thank you very much for reminding me. My name is Diana Zerl, and I serve with the Canarsie Tribal Council in Kenai, Alaska. And this is a topic that is near and dear to our tribe. And as has been mentioned, just due to the disparity in numbers that are associated with American Indians, Alaska Natives, and the frustration that we face with dealing with the opioid crisis and other substance use disorders. The as I speak to this, it reminds me of the times that I testify on the issue of why we should be looking at this being incorporated into our compacts rather than in grants, because it's every situation. And I listened to many of the other prior speakers speaking to their issues, and every community is different, which is what we all recognize in the tribal world, that self-determination is very important. So what works in one community may not work in another. And so speaking to the requirement, it's our understanding that SAMHSA, that's been reported to SAMHSA, that several tribes and tribal health organizations cannot apply for tribal opioid response funding due to the 2-year requirement in which applicants must have been providing services prior to applying for the funds. And this is kind of a catch-22 for us. It's one where we're trying to do the service, but yet we cannot do it because we have not met this requirement. And so what comes first, the chicken and egg scenario? It requires that direct clinical services for which the applicants are required to submit a statement of assurance. However, you'll find that most compliance officers will not allow their authorized representatives to sign this form due to the need to provide that documentation to the state. In turn, that is holding up some of our programs. While there is a note of a tribal exception, again, most tribes or tribal health organizations will not attest to this requirement because it does not exist. The 2-year requirement is definitely a barrier. I apologize, I think there's some background noise. The 2-year requirement is a barrier for tribes and tribal health organizations to even apply for the funding. So again, as I mentioned, it's very much a chicken and egg scenario. And in the meantime, our members are dying. It is something that is essential to create the foundation and capacity to begin the services funded through the SAMHSA programs. We believe that this should apply to all SAMHSA grants, including tribal set-asides. For without that, our tribes cannot get their foot in the door to begin building capacity to do the work because they are shut down from even applying. And as I've said it several times, but I will say it every time, is that people are dying as this is occurring, and our families are being impacted in many ways other than just the person who was directly impacted by the opioid misuse. Our recommendation is that SAMHSA require, if I had our druthers, I'd say we'd like to see it go into the tribal shares portion of our compact, but without that, that the 2-year requirement for applicants in the tribal opioid response funding be removed. It is, or that it's very clear that this exemption exists and that we're able to apply accordingly. These protections were provided by Congress to avoid development or disruption of behavioral health services that are provided among tribal health programs. Such requirements are very damaging to the ability of tribal health programs to meet their obligations to provide these services in our agreement with HHS, IHS as part of ISDIA. We recognize or would request that recognize similar policy practice for grant eligibility to help build that capacity and deliver services within the Indian Health Program. Again, this is an area that I'm very passionate about. We are seeing our young adults, in some cases our adults dying, and certainly into the youth now because of the excess access out there to this very, very, very harmful substance. And so with that, we need that ability to do what we can and not be tied up by a requirement that where we've been providing services in a similar setting, just not in what is referring to this this grant. So thank you for listening and listening to my passion on that. Thank you.
Thank you, Councilwoman Zerl. I can certainly appreciate that passion, right? When your tribal citizens are dying from, substance use disorder and its impacts. I reached out to our project lead for the Tribal Opioid Response Grant. I think it's clear in the new NOFO that 2-year prior service is not mandatory for new applicants. So I'm going to take a look again at the NOFO and make sure that it's very clear, and maybe we need to get that on a fact, but it may be still a requirement for the state opioid response, but it is not for the tribal opioid response dollars. And I apologize if, that was confusing in previous iterations of the notice of funding.
And I appreciate that. And perhaps that is something that we have misunderstood, or perhaps our compliance people have misunderstood. And so sending that out again would be very helpful. I think it just helps to reinforce our ability to apply and then work where we need to with the states or others to ensure that we're moving forward with this. I truly appreciate that. And I think it's something that the states should be aware of as well. And I know that's a different advocacy, but it certainly is an area where I happen to sit on our Governor Advisory Committee on the opioid response. And one of the things I say at each and every meeting each month is that you cannot throw enough at this to make this problem go away. And so working together, pursuing this is going to be very, very important. Thank you very much for your time today.
Thank you. And please, if there's still confusion, reach out to my office, and we're happy to support you in any way in making sure that we have the right information there for you.
Thank you.
I would like to add, if there's any tribal leaders that would like to ask a question or make a comment, to go ahead and raise your hand and unmute yourself, or you can put it in the chat box here. But I also want to share that there was a direct message asked. What's the process for IHS tribal pharmacies, SUDS, OUD programs to obtain Narcan? Some tribes noted in ITCA MAT tribal listening session last week, difficulty accessing supply shortages. Captain Hurd, I think that was a question for you.
I'm sorry, I thought it was an IHS question.
What's the process?
Yeah.
Yeah.
Go ahead.
It is.
Okay. Yeah. I think we may have lost Dr. Segay, but I'll look into that. About it sounds like there may have been a shortage, and that's what's been the issue with accessing Narcan through our pharmacies. I don't have anything right offhand on that. I'd have to follow up with our pharmacy program to see what they've been seeing on that. Thank you.
Thank you, Daryl. Do we have any more questions from tribal leaders? Just did a brief scan of the, don't see any at this time.
I would like to add to the comment that I had about, or the request that I had in regards to the law enforcement and mental health. And then I believe it was Mr. Davis that had responded about the detox facilities. And almost the majority within Indian country with tribal health clinics, IHS, there's no detox centers. I'll just say there isn't any, because I don't know of any. Being from the Midwest or the Great Plains, I don't know of any. And the reason it's such a topic, because considering with the pandemic and that it took precedence over the epidemic stuff, being the meth suicide, things like that, it was a huge need and there was nowhere to go. And even today that we struggle with it. But the other part in regard, and I know this isn't your area, but this is the struggle that our healthcare providers have, and that's with EPCs. And if you're 638, hold on, my computer's going to restart. If you're 638 and for BIA and your law enforcement, it received a notice. Most BIA 638 law enforcement agencies have that they're restricted from doing the transports for an EPC. So either they had to have committed a crime or something in that nature to get the help that they need. And very similar to what Mr. Davis had said about the gentleman, the officer waiting for treatment facility. And most treatment facilities require you to be detoxed. And most times when they get to that point, a week or two later, then they decide they don't need treatment. And then the cycle starts all over again. And then the next time might be the last time, or there won't be a next time. But that is another struggle that we have with in regards to detoxing and EPCs.
Hi, this is Florinda. I just wanted to share a response from DBH in regards to the question that was asked there on law enforcement and mental health. And so I do concur with you all, yes, in a community, especially with stabilization during a crisis, mainly a suicide, it seems like all local resources really need to come together, to develop some sort of plan to help in stabilizing. Not just only during the crisis, but in the aftermath, when the discharge happens, what other resources, can we help to build around the person, to help them start to establish a healthy lifestyle. So that's very important, but there has to be a system set in place there. And so I just wanted to make mention that we do have our PARS, which is Preventing Alcohol-Related Death Grants. So currently we do have Ogallala Sioux, who has a facility, and also Gallup, New Mexico, they have a facility. And so I believe within their detox, pretty much they do have a variety of services there. So I believe there's individual psychotherapy that happens there. There's group psychotherapy as well as group education. They do provide to an extent medication management. And so I also believe they have some sort of like a homeless program to where they help some of the individuals there, who come in, providing a place to stay there. And so again, we are working on a new notice of funding opportunity for the PARD to come. And so that's going to be pretty much open to anyone. So I just wanted to make mention of that. Thank you.
Thank you for that, Ms. Segay. So now we'll open it up to, go ahead.
Oh, I'm sorry, this is Daryl Laroche again. We have our ASA lead on from IHS, JB Kinlachini, and I think he can provide an answer or response to the question that you had on Narcan.
Hi, good afternoon. Can you guys hear me? Sound check? Great. Hey, thanks for the excellent, wonderful discussion. My name is JB Kinlachini. I'm the Alcohol and Substance Abuse Branch National Lead, and I currently have my colleague Cassandra Allen. She's the Community Opioid Intervention Pilot Project Officer. And the question about Narcan, about how to access and purchase Narcan, there are quite a few resources that are out there that make it allowable and eligible for programs to purchase Narcan. One of the things that we have is we are asking tribal communities to work with their local IHS pharmacies to be able to connect and get some further information about how to purchase Narcan. And I'll turn it over to my colleague for other additional resources that could be that is currently available. Sandra?
Yes, hello, good afternoon, everybody. So thank you for that question. As JB said, it's definitely an important one, and we want people to get access to Narcan as much as possible. So IHS does provide Narcan through their local pharmacy, so it's good to check there. We also have some Indian health boards that are also providing Narcan, as well as through the state. There are some communities that are able to receive free Narcan through the state, as well as they can purchase Narcan. And Narcan can, a kit can be anywhere from $50 to $70. So I don't think, oh, and then of course with our grantees, like, SAMHSA has grantees, the tribal opioid, the SOAR grantees, the state opioid grantees, and then our community opioid intervention pilot projects, excuse me. We also have some grantees that have purchased Narcans, and then what they're doing is they're going out into communities and they're doing drive-through Narcan training or on-site community or even virtual training. And then they provide the kits. And then some are even taking it a step further, that when either community members or businesses are trained out in the community, they provide a sticker that is placed somewhere that it's visible to the community, so that way, if there's an incident that happens, then they know who might have Narcan that they can go to. So definitely take advantage of that and pass the word along, please.
Yeah, we encourage all of our grantees to use the grant dollars to purchase Narcan as well. So I believe our colleagues at SAMHSA also support that as well. Thank you for that question.
I'd like to open it up to anybody that's on the Zoom here, but I'd also like to say thank you to our tribal leaders that did ask questions and make comments. And if we do have any other elected tribal leaders that would like to speak, we will now turn on your mics so you can ask questions.
Councilman Tyler has his hand raised. Timothy.
Nate Tyler.
Councilman
Oh, I'm sorry.
Tyler?
Okay. Nate Tyler, then we have Laurie Hayward following Nate.
Okay, appreciate that, Gwen. Nate Tyler again. So the issue I want to address is the GIPRA reporting requirements. We do appreciate SAMHSA trying to reduce the reporting burden on providers and patients. We wish to raise concerns about ongoing GIPRA reporting at SAMHSA. SAMHSA GIPRA reporting measures have been a massive burden on providers. This is also true for general reporting requirements. As an example, the GIPRA reporting requirements for the COVID-19 funds took more time than the delivery of services. Tribes and tribal organizations frequently find that the reporting requirements use more administrative resources than the SAMHSA funding allows. Currently, SAMHSA grants are set with a 20% administrative funding cap, but grantees frequently find additional resources must be expended to complete the reporting requirements. In other cases, many tribes and tribal organizations lack the time, the staff, and the resources necessary to meet the GIPRA grant reporting because of this. They are unable to apply for those grants. In other instances, tribes have given back grants to SAMHSA because the reporting burden was so high. We must say current grant reporting requirements are preventing tribes from accessing behavioral health resources. Additionally, the GIPRA reporting questions and questionnaires are not culturally competent for American Indian and Alaska Native patients and participants. We would like to reiterate our previous request that tribes must be exempt from GIPRA reporting requirements, so more resources could go directly to services instead of being redirected to culturally oppressive data collection, data entry, and data reporting. SAMHSA should let tribes decide how they can best report their outcomes instead of requiring a culturally oppressive and expensive data collection effort. All GIPRA requirements from all HHS agencies, including SAMHSA and IHS, should align reporting requirements and measures for tribal nations to improve consistency and reduce question burden on providers, clients, and patients. The request that we have is that SAMHSA should maintain the ability to collect GIPRA data via telephone and other electronic means, web-based surveys. These questionnaire completion modalities have created easier means for patients and clients to provide information, boosting response rates, and likely improving data reliability overall.
Thank you for those comments. And, we've heard those same comments loud and clear from our TTAC and also the STAC. And we've taken back those comments to the SAMHSA programs that are responsible for GIPRA. So we're currently have convened a SAMHSA kind of like interagency work group that's looking at GIPRA. And we are also elevating your concerns with that work group as well. We definitely don't want tribes to not apply for this vital funding because of GIPRA requirements. So I hear you 100% loud and clear, and we're working to try to address that now at SAMHSA.
Captain Hurd.
Thank you. To our audience again, Lori Hayward, would you like to ask your question? Please unmute yourself.
Yes. Hello, yes, my name is Lori Hayward, and I am the chairperson for Bigger Health Services in Northeastern California. I'd just like to make a few comments regarding detox and within our nation and our community and our neighbors. There is only one or two detox centers here in Northern California, Northeastern California, Northern California, which just in Shasta County. And that one detox is always very full. So for people who are ready to provide treatment for through the funding source, we are struggling with getting them into the detox center when it is time. And most treatment centers, or all of the treatment centers, are requiring 72 hours of not having using any alternative substances. So with that, it's very difficult, very hard, and very disheartening for us to either want to have to be put on a waiting list, to tell the person that detox isn't available due to their full capacity, or they decide to go back out because there isn't enough available. So we here, are also struggling with transportation at times to get our patients and clients to the nearest treatment centers. Which there is treatment centers. There's probably two treatment here locally that are always at full capacity, along with sober living. We also did, faith-based, which to each his own. I want to believe when our patients and our clients and our people are asking us for culturally sensitive treatment, we have to send them. We send them down to San Francisco or sometimes even further to receive this treatment. So we're very, we're all we 100 miles square, and not all the continent. And so we try to figure out the best ways is to be able to provide these services for our members, our community, and people that are receiving that receive services at our clinics. I also just want to, this is dear to my heart, as I've worked in concepts for many years, and I've also known that Scott Lodge works for us here, and we don't have enough of those which we practice. Some may use it, some may not. But in order for us to be able to provide a service, we'd like to, the dollars that are available are just not coming down. In the past years, it's always been, we have to pick and choose about treatment and who's not. Through that, I would initiate that SAMHSA continue to look to the communities and tribes as to what it is their needs are, and to help us initiate and provide the knowledge for us to be able to provide treatment than the soda. Thank you all for your comments. I appreciate it. You're back in the country. We are definitely a nation that is always looking to ask for so that you know that if you ever wish to come visit our nation, please do so. Said we're in Northeastern California. We invite you, any and all that wish to come visit us or chat with us. Thank you and have a good day. Over.
Thank you, Lori Hayward. We had a little trouble hearing all the information, but if we can get any response to the questions or parts of it we heard, that'd be appreciated.
Okay, I apologize. I'm riding in a car right now. I apologize. That may be why.
So my apologies. I was having difficulty making out a lot of what was shared. I think I heard, there was difficulty to access to treatment and to detox in particular. And my apologies, but I missed at the very beginning. Where are you located?
We are in Northeastern California, in the foothills. We're known as a 100 miles per hour nation.
So I was going to suggest, we definitely like to, work with you more to identify how we could support. Emily Williams is our SAMHSA regional representative for that area. And I think she's been working closely with several of the tribes there. If you reach out to our office at OTAP, I can make that connection as well. And maybe we can continue this dialogue.
Okay, thank you. I have one more comment. As we know today, the opioid crisis is still running rapid across this entire nation. I'd also like to express the methamphetamine use amongst the people. But they are now putting fentanyl in the methamphetamine, and there's methamphetamine is not understanding the cocaine. People are lazy. They're lazy with that, and so we're having more numbers of heart attacks, ODs, methamphetamine, so and other inhibitors. So I just want to express that, and thank you for your time. I appreciate it.
Anecdotally, that's what I've seen a progression throughout my career. When I first started doing treatment services, people would present, with one substance, alcohol or, marijuana, or then it was methamphetamine. Now it seems like many people presenting are for poly substance abuse, and then we're seeing, where we had heavy areas of methamphetamine use, fentanyl is now showing up in that methamphetamine or that cocaine. So it's very worrisome and kind of really indicates, how we have to have just such a broad continuum of treatment, prevention, treatment, harm reduction, and recovery services, for those people that we're serving.
Yes, thank you, ma'am, for your comments. I appreciate you.
Looks like Chairwoman Diana.
Thank you very much. Again, Diana Zerl with the Canarsie Tribal Council in Kenai, Alaska. And a comment was made earlier, and I know this is a little bit off because I believe it was an IHS response on it, but I did want to ask when the information about the availability of naloxone and how that's getting out to the tribes. And this reason I mentioned about the Governor's Advisory Council on Opioid Remediation for the state of Alaska. One of our presenters, or two of them actually, came in with the issue that the Narcan resistant opioids that are out there. And so that naloxone either having to double the dose or just not being effective at all has become a concern, and that there is now a recommendation to use another drug called Claxidol, I believe it is. And I'm just curious, within IHS, are we making that available? And again, I don't know if that's a discussion to Daryl or somebody else on that issue, but it is a concern because with more and more fentanyl showing up, we've had a huge influx of it in, the middle of the state, just above Anchorage, and now reaching out into our villages, and the issue of not being able to have a response and then in turn have an opioid death because Narcan or naloxone will not help. Do you know anything about that, or if it just needs to come out later? I'm just curious. Thank you.
This is Daryl. I'll follow up on that with our pharmacy program unless I have JB or Dr. Segay has a quick answer to that one.
Thank you.
Hi, this is Clorinda. So thank you for that additional information. We try to stay on top of what's the latest, out there on the street, keeping up with that. So I just want to make mention that we do have a group that we work with, which is the HOPE Committee. And so JB, he does work closely with them. So they pretty much are comprised of just the different discipline background as far as pharmacy goes. So they're ones that we use a lot, to help us to stay on top of our game, with such findings that come out there. And so that one is a new one for me. And I want to defer to JB. JB is our SME, so he would have more information as far as what you just made mention there. But thank you very much, ma'am. JB?
Thank you.
We do have another question from the audience. Rose Hammock, would you unmute and ask your question? Thank you.
Hello, Chente, how are you? My name is Rose Hammock. I'm Pomo Wailaki and Maidu. I live here in Santa Rosa, Sonoma County. I currently sit on 2 boards with CRIB, one being the Tribal Opioid Advisory Council, and the other is the California Tribal Epidemiology Center Advisory Council. And through COVID, here in Sonoma County, as well as Lake and Mendocino County, we had a very large amount of our community members passing away from fentanyl overdose. And CRIB was really effective in providing me with naloxone kits. And we set up Zoom, and we're doing remote Zoom naloxone trainings. So far, we have been successful with giving 2. And I've been able to provide about 15 of our community members with 4 naloxone kits each. And now they are all certified to provide that if needed. I also just wanted to share a Nixel Alert that we received in Santa Rosa yesterday here in the chat, just to express the amount of and how big of an issue this is within our urban communities as well. I think often people see it as this is just an issue with our rural communities. As Diana was sharing our relatives up in Alaska, often I think of, a lot of these issues happen amongst our people that still live on the reservations and the rancherias we have here in California, but we often forget how much of an issue this is as well for our community members in the city. And I apologize for any trauma that may come up with the Nixel Alert, but 2 young parents, toddler, came in contact with fentanyl yesterday morning and lost its life. And we have a lot of stories like that happening here in the city, and it's whether it being in our native or non-native community, it's a huge issue going on. And I just wanted to share my gratitude for CRIB that has helped give me the voice in the community here to provide the training that's needed. and to also be able to provide specific trainings just for families where we're sitting with grandmas down to the children, explaining why this is so important and why this is so needed. And I just want to express my gratitude for this listening session as a community member, because everything I'm getting from these listening sessions, I'm returning back to community and sharing resources. And as a community member, I'm very grateful for these sessions and for all this information. And thank you for allowing me to share.
Well, thank you for all the work you're doing in your community. So sorry for the loss of that baby. Definitely, getting naloxone kits out to people like where they are needed is, super important. And, with the majority of our tribal citizens living in urban, or suburban areas, we can't neglect, our brothers and sisters there. So thank you for all the work you're doing and sharing that.
I'm Central Time, so it's 3:50.
We are nearing the end of the session.
Okay. Someone has a question?
No, I said we're ending the session.
Oh, that's someone said I have a question. Okay, so we have come to the end of our time, and I want to thank our speakers very much for joining us, and tell us to all of you who shared your thoughts, comments, and questions during the session. So Dr. Hurd or Captain Hurd, do you have any closing comments?
I want to thank everyone for taking your valuable time to share with us today, and to say thank you on behalf of Dr. Delphin Rittman and my colleague Kim Beniquez. We are going to take back all of your comments and everything that we've heard today, and figure out ways to make your voices heard at SAMHSA to move forward these recommendations in our programs. So thank you.
Dr. Segui, any closing comments?
Yes, thank you for the opportunity to allow us on behalf of our leadership, Ms. Elizabeth Fowler, as well as our Office of Clinical and Preventive Services, Mr. Laroche. And so as Division of Behavioral Health, we do strive every day to look for ways of effectiveness and improvement, to assist Indian country. And so again, we always try to strategize, we always try to reach out, use all of our resources, to the best of our abilities, to try to help, tribes as far as, what's going on within the communities. And so I just want to thank you all for your work and continue to do a job well done. Also, thank you to National Indian Health Board and Stacy Bowling and her team for always hosting this listening session. It helps us to get all on one page, what we need to do, and, that our job's not done. And my condolences to all those that have been lost because of suicide, as well as any behavioral or mental health. I always call it a pandemic because it seems like it's always there, irregardless, and it seems like it's starting to, have this more larger effective overdose. Just like now we heard that Narcan no longer is working, so we're always trying to find ways. But I also like to defer to my leadership, Director, Mr. Laroche. Thank you.
One more thing.
Thank you very much. I'll just say thank you all very much for the invitation. As always, it's great to hear from the tribes and the tribal leaders. And again, just reiterate everything that everybody said with, really do appreciate all the work that you do in your communities and bringing that voice to us. And it really does help to inform how we move ahead. And we're all here for improvement. And it's great to see our SAMHSA colleagues, and as Chief Smith had mentioned, getting the VA and CDC and so forth together, because it really is one of these efforts that really needs everybody to come together and work together. Thank you.
Yes, and thank you, Dr. Laroche, Mr. Laroche, Dr. Delphine Rittman, Dr. Segay, and Captain Hurd, and all our other federal partners. We appreciate you being with us today. We will be following up with you on issues we discussed today. We know that having this time is important, and it's also critically important for us to track the progress of these recommendations. We trust that the agencies will help support our recommendations, and tribal leaders across the country will work to make sure lawmakers also know what our priorities are. We invite you all to come back and join us for the rest of the summit, which kicks off tomorrow during the opening plenary session tomorrow. We have the privilege of welcoming back Dr. Delphine Rittman and Captain Hurd, who will be providing remarks. We also will have remarks from Vice President Kamala Harris. We also welcome you to join us for the Intertribal World Cafe on Health Equity on Friday at 12 p.m. Eastern Time. Thank you again to our speakers and our audience members. Please take a few seconds at the end of the session to fill out our evaluation form. You can find a link that says, please fill out the session evaluation under the description on the session page on the online conference agenda. This feedback is critical for the work that NIHB does and helps us improve the listening sessions for the future. On behalf of the entire NIHB board and staff, I wish you a good week and hope you all enjoy the rest of the summit. And just wanted to say a couple of special words out to everybody. This is a very difficult session. I know that a lot of information that was shared and discussed today hits Indian country hard. Here at Fond du Lac Band of Lake Superior Chippewa Human Services, we struggle through these issues daily with our departments, our staff, looking for ways to support each other. So miigwech for tuning in and participating in this session. Miigwech.